angle tenderness, pelvic or perineal pain in males, and symptoms of cystitis may or may not be present. So, and patients who are having underlying urological abnormalities like nephrolithiasis, strictures, stents, urinary diversions, so they are considered as complicated UTI. And UTI in immunocompromising conditions like neutropenia and poorly controlled diabetes are also considered complicated UTI.
Any issues, Harsha?
Yeah. It's okay, ma'am. Now, so complicated UTI, we can have cystitis, which is more complicated, emphysematous cystitis leading to sepsis. We can have pyelonephritis. We can have recurrent UTI requiring multiple antibiotics, and we can have catheter-associated UTI. And UTI in men is also classified as complicated UTI according to some authors. So any UTI leading to urosepsis is also complicated UTI. So directly we'll go to the emphysematous pyelonephritis. So emphysematous pyelonephritis, based on the radiological description, particularly CT based, computer tomography based classification, there are two types, type 1 and type 2. Type 1, we have renal parenchymal necrosis with either absence of fluid collection or presence of a streaky or mottled gas pattern. Whereas in type 2, we have renal or perirenal fluid accompanied by bubbly gas pattern or gas in the collecting system. So basically, this is it usually depends more on the host factors. In type 1 emphysematous pyelonephritis, the host is importantly very immunocompromised, either uncontrolled diabetes, and there is not much immune response. So we are not going to see much renal or perirenal fluid collections. We are directly seeing some necrosis, which we are seeing on the imaging as presence of gas. So basically, in type 1, there is more vascular thrombosis, it is more fulminant, and the duration of symptoms are very short, and it is more acute onset. And this type 1 is having more mortality compared to the type 2. And on pathological examination, necrosis and hemorrhagic infarction is very common in this type 1. So as you see in this picture, so if you see the kidney, it's more of gas-like collection, which is representing necrosis of the parenchymal tissue and production of gas because of the gas-producing organisms. So this is the same coronal section of the same kidney. Whereas coming to this picture on the right side, so it's more of abscess-like collection, which means there is some host response which is trying to localize the infection, which is trying to prevent spread of the infection. Basically, this accounts to type 2 type of emphysematous pyelonephritis according to radiology. So why we need this classification, I will discuss further. So basically, this is type 1 and type 2 is one of the earlier classifications. Later, some other classifications proposed by Michael, a little bit modifications by Huang. So basically, this classification also gives us approach for the way of management we want to do, and it also gives prognosis in a better way compared to the previous classification. So basically, in this newer classification, radiologically, the emphysematous pyelonephritis is classified into four types. Class 1, in class 1 emphysematous pyelonephritis, the gas is confined more to the collecting system. It is more of pyelitis than nephritis. It is more of pyelitis. Coming to class 2, the gas is confined to renal parenchyma. So it is both pyelitis plus nephritis. Coming to class 3, it is extension of the gas or abscesses beyond the kidney. If it is perinephric, it is class 3A. If it is Beyond the fascia of the kidney, it is class 3B. Once the emphysematous pyelonephritis is bilateral, it is class 4, or any emphysematous pyelonephritis in a solitary kidney situation, it is class 4 emphysematous pyelonephritis. So basically, this classification is helpful for us to decide the management. Usually, any simple pyelonephritis, we know we are giving systemic antibiotics according to the local microbiology reports, and usually the minimum duration we give is around 7 days, and we may prolong to 2-week course based on the clinical recovery and also defervescence. So coming to class 1 emphysematous pyelonephritis, where the disease is more concentrated around the collecting system. So once there is no abscess formation, just giving systemic antibiotics is good enough. But coming to other classes like class 1 emphysematous pyelonephritis with abscess formation, or class 2, we need to do some percutaneous catheter drainage either from the PCN or through DJ stenting. And we have to, if at all any obstruction is present, we have to relieve the obstruction along with systemic antibiotics. So coming to class 3, antibiotics plus percutaneous drainage plus relief of urinary tract obstruction is must and should. However, if management, if the sepsis is ongoing, or if there is no good clinical recovery, we have to go for early nephrectomy also from class 3 emphysematous pyelonephritis classification. So nephrectomy is indicated in all patients where percutaneous drainage is unsuccessful, is not if there is no hemodynamic improvement in the patient. So basically, diabetic patient comes with fever and UTI. So supportive management, we are doing a imaging. If imaging is normal, so it's a simple pyelonephritis, we can treat for 7 days. But if there is hydronephrosis with obstruction, we have to give antibiotics and also remove that obstruction and place a stent. If there is gas in the KUB CT or USG, so basically it is emphysematous pyelonephritis. If gas is only present in the collecting system, drainage and antibiotics. If gas is present in the renal parenchyma also, so if it is class 2, we have to do percutaneous drainage and continue our antibiotics. If it is class 3, we may need to go for nephrectomy. So any of the emphysematous pyelonephritis, if it is not improving clinically, we have to go for nephrectomy. And in a bilateral emphysematous pyelonephritis, it's very tricky decision, because if it is unilateral, to save the patient, we can go for nephrectomy. Whereas in a bilateral emphysematous pyelonephritis, we cannot do nephrectomy for the both kidneys unless we are sure that this procedure is going to make patients survive. So yes, now coming to recurrent UTI, a simple definition: if more than 2 episodes are happening in past 6 months, or 3 episodes in 1 year, we call it recurrent UTI. So most recurrences usually occur within 3 months of the previous UTI. So reinfection is most common in recurrent UTI. So new infection followed by eradication of the prior one. The other thing is relapse, re-emergence of the prior infection, which was incompletely eradicated or which was incompletely treated. So usually this relapse occurs within 3 weeks of completion of the partial treatment. So basically, recurrent UTIs also require extensive evaluation. So coming to the treatment, recurrent UTI is also treated like any other UTI or pyelonephritis. So the duration of antibiotics, everything is same, but sometimes recurrent UTIs also happen on antimicrobial prophylaxis. In those scenarios, a repeat urine culture is required. And we have to suspect MDR organisms if in the past 3 months, if patient is colonized with MDR organisms. So the prevention of recurrent UTI, we need to counsel for liberal fluid intake, modification of contraception, particularly if they're using any spermicidal gels which are applied intravaginally, that should be avoided. Postcoital voiding is something we have to inculcate in those people because the incidence of UTI decreases with postcoital voiding. And local hygiene. So in postmenopausal women, vaginal estrogen might help. So coming to methenamine, cranberry products and probiotics, I'm going to discuss in the next slide. The antibiotic prophylaxis should be the last resort after trying all the behavioral changes and whatever the hormonal supplements and the other products which I'm going to discuss. So basically, this is one of the RCT which is done between 2013 to 2016. So 140 women. So usually they are drinking less than 1.5 liter of fluid. So the intervention which the author did in this study was to give additional 1.5 liter of water to the water they are taking. So the outcome measured was frequency of recurrent cystitis over 12 months. So you can see in the bar diagram. So the dark bars are in the water group. The light one are the control group. So there is significant difference in the episodes of recurrent UTI. So basically, episodes were 1.7 in the water group, whereas it is 3.2 in the control group, which means a difference of 1.5. So with simple inculcation of habit of taking liberal water, we are able to decrease the UTI risk. So coming to the next one, particularly post-menopausal women with recurrent urinary tract infections. So we should also consider estrogen replacement because estrogen restores atrophic mucosa, lowers the vaginal pH, and may prevent urinary tract infections. So basically, a small trial including 93 postmenopausal women, when they tried placebo-controlled trial with estrogen local creams. So the results were astonishing. Only 0.5% in the estrogen arm had UTI, whereas in the placebo arm, it is around 5.9 episodes per patient year, with a significant p-value. So coming to the other alternatives, methenamine hippurate is a compound. Basically, it is hydrolyzed to formaldehyde, and it is something like a antiseptic in the urine. So formaldehyde denatures bacterial proteins and nucleic acids. So randomized non-inferiority trials are there. So they compared methenamine with antibiotic prophylaxis, where they saw that methenamine hippurate taken for 12 months is non-inferior to taking antibiotic prophylaxis like nitrofurantoin or cotrimoxazole. This methenamine is also available in India, though personally I have never used. So the adult dose is 1 gram twice a day. Cipla is also manufacturing this. So coming to the cranberry extracts, so basically these are polyphenols. They act as receptor analogs and binds to femoral tips of the E. coli bacteria particularly, and prevent binding to the and makes for the bacteria to bind to urothelium difficult. So basically the evidence is not that great in terms of meta-analysis, but simple RCTs have shown some benefit. But there is no harm other than dyspepsia giving these cranberry extracts. Supplementing probiotics. So these probiotics are usually given locally as intravaginal suppositories. So once 100 premenopausal women were with history of recurrent UTI were tried this local suppositories. The recurrent UTI occurred in 15% of women on this lactobacillus suppositories, whereas the placebo arm had around 27% of recurrent UTI episodes. So coming to antimicrobial prophylaxis, which we are commonly using, as I stated earlier, let us try all the non-antimicrobial preventive measures first. If these things are failing, then better to go ahead with the antimicrobial prophylaxis. So with antibiotic prophylaxis, the UTI chances are 24% to 85% lower. This is the range among different studies with antibiotic prophylaxis. So many of the studies used nitrofurantoin. There are also studies uh, where the usage was not continuous, it was only intermittent. Particularly, there are section of people where they get UTI post after the coitus. So there are studies where this prophylaxis was given for a short period after coitus also. So coming to continuous prophylaxis, so first, do a urine culture and treat the acute episode. After the acute episode is done, we have to start the continuous prophylaxis. In postcoital prophylaxis, usually the studies used a duration of 3 months, and if 3 months it is going, if it is helping the patient, there are studies which extended this postcoital prophylaxis to 2 years or more also. So these are the common antibiotics which we have: nitrofurantoin, cotrimoxazole, fosfomycin, trimethoprim alone, and fluoroquinolones are also something which were tried for prophylaxis. Uh, these are the doses of nitrofurantoin: 50 mg once daily or 100 mg once daily. Cotrimoxazole, half a tablet daily or one tablet every 2 days. Fosfomycin, 3 grams every seventh or 10th day. So nitrofurantoin, only problem with nitrofurantoin is people with steroid stones, particularly with Proteus and all, Serratia species and Pseudomonas. This is not going to help because these bacteria are intrinsically resistant to nitrofurantoin. And one more thing is we cannot use in patients with creatinine clearance less than 60 and at term pregnancy and neonates because of some hemolytic effects, particularly with G6PD deficient babies. And adverse events are not much, but there are many case reports where this nitrofurantoin prophylaxis was causing drug-induced ILD and acute pulmonary failure also. So other than that, usually we don't see much adverse effects. So fosfomycin is something we are using for antibiotic prophylaxis. So the other problem is it doesn't cover Pseudomonas. Less than 2% isolates of Pseudomonas are sensitive to fosfomycin. Basically, Pseudomonas is intrinsically resistant to fosfomycin. In around 2% of the isolates, we may see the sensitivity. Acinetobacter, Stenotrophomonas, Burkholderia cepacia, Morganella. So these are the organisms which are resistant to fosfomycin, and adverse effects are very common. Particularly, diarrhea is very common, and people also patients with heart failure and all. There are scenarios. I feel the heart failures were precipitated by using oral fosfomycin because of the sodium overload they get along with the sachets. So fosfomycin resistance is also very common. Particularly, the resistance is more in Klebsiella isolates because of the phos-A metalloenzyme the Klebsiella isolates have. This prulifloxacin versus fosfomycin. This prulifloxacin is fluoroquinolone, which can be given as a single tablet per week. Fosfomycin 3 gram sachet per week. Basically, these two drugs were compared, and there is no significant difference between these two drugs. Both drugs were doing good. The problems with giving antibiotic prophylaxis can be the toxicities associated with cotrimoxazole or the adverse events we discussed with each selective drug. And maybe once we are giving these drugs, are the bugs, because of the resistant selections, are we going to face bugs which are resistant to the antibiotics we are giving? So that is always there. And C. difficile infection, particularly fosfomycin and all, it is a broad spectrum which covers gram-negative and gram-positive like Enterococcus faecalis and all. So the C. difficile infection goes up, and alteration of gut microbiome. And though I personally didn't use, these are the novel strategies which are there when I was searching the literature. So basically, there are vaccines against E. coli type 1 adhesion proteins, so which uh, gives some immunity against the adhesion protein, and there is some role of prevention of UTI. And there are also immune stimulants, Eurovaxum. So basically, membrane proteins of 18 strains of E. coli, they will be given to the patient, and it stimulates both humoral and cell-mediated immunity. They come as commercially as 6 mg capsules daily for 90 days. So they have seen that there is significant reduction in the number of episodes of UTI. So I have never come across this practically. So coming to the treatment basically depends on the local epidemiology, the local antibiogram. So basically, the place where I was trained, or the place where I'm working now in Hyderabad, so we feel there are around 80 to 85% of our Enterobacteriaceae are ESBLs. So in 80 to 85% of our scenario of urinary tract infection, our basic third generation cephalosporins are not going to work. So we are preferring beta lactams with beta lactamase inhibitors, either cefperazone sulbactam or piperacillin tazobactam to start with. But if any previous reports of resistance to these drugs, we have to go for higher antibiotics, particularly when the patient is sick, and we can de-escalate later to the and targeted antibiotic later once we have culture reports. So basically, this is ICMR 2022 data of E. coli isolated from the OPD ward and ICU. So you can see that cefotaxime is representing the third generation cephalosporins here. Hardly 22% of our isolates in the OP are sensitive to third generation cephalosporins. So coming to the ICU, it's only hardly 16% which are sensitive. So basically, we have to take decision on antibiotics based on our local epidemiology also. The same applies to Klebsiella pneumonia also, where we are seeing a lot of resistance even to BLBLIs. I also want to just share that we have many newer BLBLIs in the market. So Cefepime enmetazobactam is readily available in India. So we are using this as carbapenem sparing, particularly after we know the Merino trial, where the arm receiving piperacillin tazobactam, particularly in severe cases, sepsis, there is some mortality benefit of using carbapenems. So because of OXA1 production in some of the isolates, where this enmetazobactam can inhibit this OXA1 and other CTXM and TEM like beta lactamases. So this cefepime enmetazobactam can be used as an alternate to cefoperazone sulbactam and piperacillin tazobactam instead of going for meropenem. So the one of the practical reasons actually I am not using cefepime enmetazobactam is meropenem per se is a lot cheaper than cefepime enmetazobactam. But here we are talking about stewardship, and maybe in that settings, yes, cefepime enmetazobactam is an alternate choice to carbapenems in these scenarios. And Vitek identification is not possible as of now for cefepime and metazobactam. We need separate E-strip testing of the isolate, and this is going to time. And that is why practically, I think many of the centers are not using cefepime and metazobactam much. And coming to cefepime taniborbactam, we can keep this BLBLI above meropenem. So it covers even endium also, even it covers even OXA 48, but endium it is not covering beyond endium 9. So basically, it is not available in India as of now, but this is also one of the BLBLI we have in treating complicated urinary tract infections. So the other product which we are seeing for around 1 or 2 years is plazomicin, the newer aminoglycoside, where almost like 60 to 80% of the isolates which are resistant to carbapenems, particularly E. coli, are sensitive to plazomicin. So basically, this is a good drug for whatever data we have right now. It is a good drug for carbapenem resistant E. coli. It's not so great for Klebsiella. Many of the carbapenem resistant Klebsiella are usually resistant to plazomicin also, but this is one of the drug we need to check for all our UTIs. And definitely, it cannot be used as a single drug in scenarios of urosepsis. So it is an alternative drug in cases of urosepsis. As we know, the pharmacokinetics of aminoglycosides is not great in scenarios of sepsis. And recent news on November 4th, FDA approved fosfomycin for complicated urinary tract infections. Previously, the fosfomycin sachet was only approved for cystitis as per FDA, but now the IV fosfomycin, which we are using in India from almost like last 5 6 years, but it got a recent FDA approval on November 4th, 2025. So I also want to share some information on fungal UTI. So basically, these are the fungal organisms which can cause UTI. Candida is most common fungi, which can cause UTI. But these are the dimorphic fungi and some endemic fungi which can cause UTI as part of their systemic infection, particularly in the settings of transplant. Uh, Renal mucormycosis is not uncommon in our diabetic ketoacidosis scenarios also, and in transplant kidneys, the renal mucormycosis is very common. Aspergillus per se is very common because of the contamination of the fluids of the transplant organ storage fluids can usually be contaminated with aspergillus and can lead to transplant kidney aspergillosis. So the problem generally we face in the fungal UTI, it's Candida. This Candida, whether it is really a colonizer or a true pathogen here, so many scenarios it is very difficult practically to know whether it is a colonization or a true infection. So we try to, if patient is on catheters, we try to exchange catheters, we try to repeat cultures after exchange of catheter, but still candiduria is persisting. We do not know to treat or not. So many a times I feel in these scenarios we overtreat. Except this is the only specific indication, the presence of fungal ball or showing some micro abscesses in the kidney, which is very specific of telling that this is invasive candidal urinary tract infection. So other than that, it is really difficult to differentiate colonization versus candida UTI. So coming to the transplant recipients, Candida arteritis is very common. This is because of contamination of donor kidney with intestinal flora during the organ harvest, particularly first if a liver is harvested, first if bowel is harvested, and later the kidney is the later organ of harvest. This is going to happen, and this is not uncommon. So basically, Candida arteritis, we are going to see a mortality. If we have diagnosed Candida arteritis, better to go for nephrectomy, because this arteritis is going to become aneurysm so quick, and it is going to rupture and cause mortality. So many patients require nephrectomy after Candida arteritis. So this slide, I just want to show in cases of fungal UTI, what are the better drugs. So undoubtedly, the tissue penetration is very good, particularly into the kidney and urine with fluconazole. The other azoles like voriconazole, posaconazole, they go into the renal tissue well, but the urinary penetration of itraconazole and voriconazole is not much, including posaconazole and isavuconazole. The urinary penetration is not good. Even in amphotericin, we have the deoxycholate, lipid complex, and liposomal amphotericin. So the best drug, the best amphotericin is deoxycholate. It has best urinary penetration. The other two, liposomal amphotericin and lipid complex, doesn't have much urinary penetration. And flucytosine is one of the drug which has good urinary penetration. Among echinocandins, caspofungin is a better urinary penetrating echinocandin. Maybe micafungin also have some studies indicating good urinary tract penetration. So coming to one more interesting and a very difficult to treat pyelonephritis. This is Xanthogranulomatous pyelonephritis. So basically, the process is so chronic that obstruction and recurrent infections go on like a vicious cycle. Obstruction leading to infection, infection leading to obstruction. It is a vicious cycle. So the kidney parenchyma slowly, instead of the kidney tissue, it is slowly replaced with granulomatous tissue, particularly containing histiocytes and foamy macrophages. So this xanthogranulomatous response to infection doesn't happen only in the kidney. It can happen in virtually any organ of our body. You can see in the cholecystitis, pancreatitis, if, in anywhere it is possible. So the infection we treat with antibiotics, but the foamy macrophages, inflammation and fibrosis, which is already formed, we cannot do anything. Obstruction, we can actually treat with degestanting or PCN, but this fibrosis, which is already formed and settled, we cannot remove it. So xanthogranuloma is a granulomatous fibroproliferative condition. So this gross pathology picture is showing some yellow tissue, which is basically the lipid-filled macrophages and inflammatory reaction. On a microscopy, it has a lot of interstitial infiltrates composed of neutrophils, mononuclear cells, and lipid-laden macrophages. So, how is there any possibility of removing this foamy macrophages with histiocytic infiltrates? So there are some case reports where xanthogranulomatous pyelonephritis is managed with immunosuppression. So there are some successful case reports. These three case reports I'm just presenting. So basically, foamy cells are lipid-laden macrophages. There is excessive cholesterol in the cell. So mTOR enhances foam cell formation by suppressing the autophagy pathway. So if we can suppress mTOR pathway, we can decrease the foam cells. So basically, mTOR inhibitors can play a role in treating xanthogranulomatous pyelonephritis. Or many a times, xanthogranulomatous pyelonephritis, giving antibiotics, stabilizing the patient, and doing nephrectomy is the usual management which is usually going on. But this can be an alternate. Yeah, thank you.
Thank you, Dr. Harsha, for decomplicating the complicated UTI. So we do have some questions.
Yes,
Uh,
ma'am.
would you like to read it, or you want me to read it out? So the first one is, what prophylaxis should be used for recurrent UTI with XDR Klebsiella that is resistant to nitrofurantoin and fosfomycin?
Maybe this is a practical scenario we face. We know E. coli, we have a good option with phosphomycin, but Klebsiella, unfortunately, we don't have much options. As I already mentioned, antimicrobial prophylaxis we have to try only after trying the non-antimicrobial prophylaxis measures. As I have shown, giving liberal water, giving uh, cranberry extract, maybe giving that methenamine, all this might help. In a postmenopausal, giving estrogen supplements locally might help. Giving lactobacillus supplements locally might help. Controlling the diabetes might help. So, what are the risk factors? I think we have to treat. That is how we can prevent in such scenarios. Continuing the, I don't think continuing drugs which are already resistant is not going to help much. But in cases of structurally abnormal urogenital tract, I still feel we have to continue, though the patient is colonized with the resistant organisms. Maybe I also like to continue some antibiotic like cotrimoxazole or phosphomycin, because it's not always club which creates problem in him. It can be some other organism also. So we can take chance to continue other antibiotics. This is how I take it, ma'am.
Yes, so we need to target the non-pharmacological measures, especially, and non-antibiotic measures for treating recurrent UTI. So, phosphor is recommended only for E. coli. That is one question.
Yeah, as of now, E. coli has good susceptibility as per the ICMR data. Fosfomycin is good drug for E. coli. Yeah, so E. coli we
E.
can use it.
coli, enterococcus, you can consider to you can use. Okay. You can respond to few of the questions. I think they are recurrent, so you can respond so that we can move to the next session. Thank you once again, Harsha, for making time and demystifying the complicated UTI.
Thank you, ma'am.